Okay, so thank you for the very kind introduction. I am at McGill University and I'm actually in my clinic, but I've put a do not disturb post-it on my door, so I hope I'm not disturbed for the next almost hour. Thanks to all of you for joining. This is a topic that is very near and dear to my heart, that is prison research. That I've been doing for almost a decade now. And so love that there's interest for this space, and I'm happy to answer questions when I'm done. But feel free if there's anything, this is very informal. Feel free to interrupt at any point in time if you'd like me to clarify anything or have a burning question that can't wait until the end. And so, similar to Amy's land acknowledgement, I'd also like to acknowledge that we are located on unceded Indigenous lands here in Montreal. The Kanien'kehá:ka Nation is recognized as the custodians of the lands and waters on which I gather today. Tiohtià:ke, or Montreal, is historically known as a gathering place for many First Nations. And today it is home to a diverse population of Indigenous and other people. We respect the continued connections with the past, present, and future in our ongoing relationships with Indigenous and other peoples within the Montreal community. And I think it's particularly important for people who do prison research in Canada to do a land acknowledgement, given the disproportionate incarceration of Indigenous individuals in Canadian prison. These are my conflicts of interest. So, sexually transmitted infections remain a pressing public health challenge. According to the World Health Organization, more than 1 million curable STIs are acquired every single day in people aged 15 to 49 years of age, the majority of which are completely asymptomatic. In 2020, the year of the last data cut, there were 374 million new infections in people within the age of 15 to 49, one of 4 of which were considered curable STIs. That is chlamydia, gonorrhea, syphilis, and trichomonas. As we all know, there's been a global resurgence of STIs, not just in other countries, but in Canada. And the most pressing problem has been congenital syphilis. 1.1 million pregnant women were infected with syphilis in the year 2022, resulting in over 390,000 adverse birth outcomes, all of which can be prevented. We know that these infections are not benign. Left untreated, they can lead to chronic pelvic pain, infertility, ectopic pregnancy among women, epididymitis, prostatitis, and urethral strictures among men. And they also increase susceptibility to HIV acquisition and transmission, both among men and women. In 2022, WHO published the Consolidated Guidelines on HIV, viral hepatitis, and STI prevention, diagnosis, treatment, and care for key populations. These guidelines outline a public health response to HIV, hepatitis, and STIs for 5 key populations. 1, men who have sex with men. 2, sex workers. 3, people in prisons and other closed settings. 4, people who inject drugs. And 5, trans and gender diverse people. In 2023, the WHO released this policy brief, which gave an update to the previous one, but also whose main focus was people in prison. And the WHO has set out 2030 STI targets, and that is that 90% of people in prison should be screened for gonorrhea, chlamydia, and syphilis, and over 95% should be treated for those 3 infections. So in 2021, in the Lancet Infectious Diseases, this was the last time there was really a global trend of sexually transmitted infections that was published. And you can see on the right-hand side that they looked at data from 1990 to 2019, and you can see that there has been a steady incline in all sexually transmitted infections globally. The most common infection globally is trichomonas, followed by chlamydia, gonorrhea, herpes, and syphilis. Without going into too much detail, you can see that on the lower panel, The age range that is most affected by sexually transmitted infections are those individuals aged 10 to 24, followed by the 25 to 44 age range. Understandable, those being peak years of sexual activity. Also, in this paper, sub-Saharan Africa had the highest age standardized incidence rate of all sexually transmitted infections. Adolescents had the highest incidence rate, as I've just demonstrated, compared to older adults. And interestingly enough, males had higher age standardized incidence rates compared to females. Just keep this in the back of your mind, the adolescents and males, as we look at the data in prisons. What has happened in Canada in terms of trends? And you guys can see that, right? Just moving my slide a little bit. So this is the most recent data from the Public Health Agency of Canada, which looks at data up until 2021. You can see for the most part, there has been a decline in the number of cases of each of chlamydia, gonorrhea, due to the COVID pandemic in 2021 due to decreased testing and screening. Ironically, this has not been the case for syphilis, where despite the COVID pandemic, there were actually an increase in the number of cases of infectious syphilis. Also, the main difference here, so chlamydia, just so you know, is by far and large the most common STI in Canada and actually worldwide, secondary to trichomonas, with over 100,000 cases diagnosed approximately every year. And about 2/3 of these infections, chlamydia, are among females. Gonorrhea is about a third of the number of cases of chlamydia cases, but more so 2/3 in males. And similarly, infectious syphilis, much smaller in scale, so 1/10 the number of infections as chlamydia, but similarly 2/3 cases among males. So chlamydia, primarily females, hundreds of thousands of cases, gonorrhea and syphilis on a much smaller scale, but 2/3 among males. So prior to the work that we did, there was a systematic review that was conducted in the United States, and I'm not going to get into this in too great detail, but it's interesting to note that this work, led by Anne Spalding, who's out of Emory University, went on to contribute to CDC's treatment guidelines for STIs in prisons. So her recommendations based on their systematic review was that all females less than or equal to 35 and all men less than 30 should be tested for chlamydia and gonorrhea in all U.S. jails and prison. And this is because they did look at age and incidence of STIs and felt that the cutoff for women should be 35 and men 30. They did not make such a universal recommendation for syphilis, but made a recommendation that jails and prisons should determine whether they should screen for syphilis based on surrounding local epidemiology. And so if you have a higher surrounding or in the community prevalence of syphilis, then the recommendation would be to screen. And if not, then there's likely less indication to screen from a cost-effective standpoint. And then trichomonas, again, all women less than or equal to the age of 35. So really interesting work that actually changed the dial in terms of how prisons and jails screen for bacterial STIs in the United States. So with this in mind, cognizant that there had not yet been a global evaluation of the prevalence of bacterial STIs worldwide, we set to estimate the global prevalence, and we focused solely on bacterial STIs, chlamydia, gonorrhea, syphilis, given the global surge in these infections among people in prison. And we similarly wanted to assess variation by age and sex. I'd like to give a special nod to Gabrielle Baudry, who is a medical student here at McGill and has a PhD from Oxford, and led all the work and all the analysis. And this is the other members of the team. So what did we do for our systematic review and meta-analysis? We searched 9 academic databases and major grade literature sources, covering publications from January 2000 to August 2025. So 25 years of literature. When you're doing a systematic review and meta-analysis, you always want to choose a start date that makes sense. So we chose the year 2000 specifically because that's when the WHO and other UN organizations had started to at least make some noise about people in prison being important to screen. So we thought that that may be an important turning point in testing and studies done in prison. We included only studies where there was a biological confirmation of chlamydia, gonorrhea, and syphilis. And what I mean by that is that there had to be a test that was done. So no self-reporting was allowed in terms of inclusion for the diagnosis. And we stratified individuals based on age, so adolescents less than or equal to 19 and adults greater than 19. And that was consistent with the UNESCO definition for age. We also excluded non-bacterial STIs without disaggregated data. And what I mean by that is that they didn't disaggregate the data by sex or by age. They kind of pooled everything together within one STI category. And the analyses were mixed effect meta-analyses that, again, as I mentioned, we stratified by age and sex primarily. So our outcomes were the following. We had 3: current chlamydia infection, current gonorrhea infection, and current or prior Treponema pallidum or syphilis infection. And the reason why we could not just limit ourselves to current syphilis infection is that there were significant limitations in the diagnostic reporting of syphilis. Many studies did not qualify the actual test that was done, and so made it extremely challenging for us to determine whether it was current or prior. And so this resulted in our aggregation of current and prior syphilis into the outcome measure. So just keep that in mind. It means that likely there's an overestimation of the syphilis prevalence that we found in this study. So here are our results. You can see that from our database search, there were over 5,000 studies, over 2,700 of which were removed. And Gabby and Brendan then screened over 2,500 studies to then get to 212 studies that were included, 206 of which were unique. So you can see here a little bit of details about the studies that were included. Their majority were among adult participants only, so greater than the age of 19. A third of which were among adolescents, and 16 studies had both adults and adolescents. We had over 1.4 million people included in this study, 2/3 male, a third female, and 4% unspecified. The mean age among adults was 34 years, adolescents 16 years. We classified countries as per World Bank income classification. So that's low, middle, and upper middle combined as middle, and then high income countries. And you can see the predominance of high income countries. And unfortunately, in the low income country setting, there were only 2 studies. The studies themselves spanned 43 different countries, with the highest representation from North America, including the US having almost half of the studies. South and Central America comprised about a quarter of studies, and most studies from Central and South America originated from Brazil. So here are the results by each infection. So chlamydia prevalence was assessed across 114 unique studies encompassing over 760,000 individuals. And you can see here the breakdown of adults and adolescents. And I hope my pointer is working. So on the top, the panel A is for adults and panel B is for adolescents. And here we've also included a map to show you where most of the studies came from, with the darker red comprising the highest prevalence of studies. So you can see here that most studies came from the US, very few from Europe, and absolutely none from Africa. So among adults, we're going to look at the overall prevalence of chlamydia among people in prison was 5.7%. And you can see here that women have a higher prevalence of 6.5 versus males who are 4.7. When you look at adolescents, the overall prevalence is 11.9%, so twofold higher than among adults. You can see the female prevalence is significantly higher at 16.8 compared to the male prevalence 7.4, which is lower than the overall prevalence among adolescents. When we look at gonorrhea, fewer studies on gonorrhea, so 89, but covering over 620,000 individuals. Again, often chlamydia and gonorrhea go hand in hand in many studies, so it's not surprising that the map that you see here looks very similar to the map you saw for chlamydia. And again, no studies in Africa. When we look at the prevalence among adults, so the overall prevalence was 1.0%, higher again among females at 1.5, and lower than the overall prevalence among males of 0.4% in men. Among adolescents, again, what's interesting here is that the overall prevalence was 3.5, so threefold higher than among adults. With females, again, significantly higher at 6.0 compared to males at 2.0. For syphilis, we assessed the prevalence across 125 studies. Over 690,000 individuals were included. And interestingly, you can see here that Brazil is the darkest red that we had, and so they actually had the highest number of syphilis studies. So looking at the prevalence again among adults, the overall prevalence was 4.5%. Female adults had a higher prevalence at 5.9% compared to males, which was 3.7%. Among adolescents, there were much fewer studies, and so you can see here that there are quite wide confidence intervals. The overall prevalence was 1.9%, but very few also studies disaggregated by sex, limiting our ability to determine an accurate prevalence, but both male and female were estimated at 1.9%. Okay, I just wanted to sort of give you a visual of the sex-based differences that we found, because it's quite hard to see them in those plots. But the adults are the first three bars of every infection, and the last three bars are adolescents. So you can just see that for chlamydia and gonorrhea, the adolescents, as was pointed out in our last few slides, much higher prevalence, except for syphilis, but there are limitations. And then when you just focus on the females, either adults or adolescents, in every infection, except for syphilis among adults, the female prevalence of every single infection is higher in prison compared to males. So I do want to discuss the limitations of the work, although this was a tremendous amount of work given the numerous studies. There are limitations to every single study, and one of the most important limitations is the inconsistencies in the reporting of diagnostic assays, which limited the precision of our prevalence estimates. As I mentioned earlier, this was particularly relevant for syphilis, where the specific diagnostic test, whether treponemal or non-treponemal, was often unspecified. As a result of that, we couldn't specify whether the authors were diagnosing current or prior syphilis. Also, there are several high-risk subpopulations within prison. So in prison, it's already a higher risk population for STIs, but within prison, there are numerous subpopulations that are at even increased risk of STIs. And unfortunately, we were not able to estimate risk among these high-risk subpopulations because very few studies actually reported data by race or ethnicity, by gender identity, or even by HIV status, or among people who inject drugs, commercial sex workers, racially minoritized group, all of whom are at higher risk of STIs. And so while this is very useful work, we would have loved to take a deeper dive and be able to comment on risk by subpopulation, which we weren't able to do. And then there was missing primary data. So despite our efforts to contact authors of the primary studies, when raw data was not unavailable, responses were limited. So we had to occasionally convert pooled or transformed prevalence data into raw numbers to calculate our own prevalence estimates. And then unfortunately, as I've mentioned, there's simply a dearth of low and LIC, so low income country data, where only 2 studies were reported. And so I'd like to name a few conclusions and the recommendations that we have made as a result of our findings. One conclusion is that there's a high bacterial STI prevalence, so clam, gono, syphilis, in incarcerated populations worldwide, which underscores significant public health gaps in bacterial STI prevention and treatment for populations that experience incarceration. And so with that, it is important to recommend opt-out bacterial STI screening to all people on admission to prison. Second, the pooled prevalence of chlamydia and gonorrhea were several-fold higher amongst adolescent males and females compared to adult men and women. So if you are in a resource-constrained environment, and there are not endless amounts of money, then we have recommended that opt-out screening at least be prioritized for individuals aged 19 or less at prison admission worldwide. We've also shown that the pooled prevalence of each bacterial STI was 2 to 3-fold higher among females compared to males. And this argues for the fact that all incarcerated females worldwide should be offered opt-out bSTI screening. Again, if resources are limited and we had to prioritize, it would be based on age and by gender. Fourth, we found a high prevalence of bacterial STIs among people in the high prevalence of bacterial STIs among people in prison suggests the need for effective primary and secondary prevention programs. And with the goal of ensuring sustainability and cultural competency, it's recommended that we engage people with lived experience of incarceration in program design and evaluation, and in particular, women for gender-sensitive, trauma-informed care. And finally, that comprehensive yes, while we have recommended that bacterial STI screening be prioritized on admission, we have to remain cognizant that many of these infections are co-occurring with other STIs, including HIV and viral hepatitis, and they should be screened all simultaneously to ensure that no infection is missed upon admission. So I am very happy to report that this tremendous amount of work was published in Lancet Public Health, which was just earlier this year. So feel free to take a deeper dive if it's of interest to you. Now for the second half of my presentation, I'll talk about a real-world study that we are conducting here in the province of Quebec to look at the prevalence of both bacterial STIs and a broader scheme of sexually transmitted infections and bloodborne infections. So I hope that I've convinced you that people in prison must be prioritized for the elimination of STIs in Canada and globally. And as I mentioned, WHO in 2021 identified people in prison and other closed settings as a key population, and our data supports that. Why is the prevalence of STBBIs higher among people in prison than the general population? This is thought to be for many reasons. One, we criminalize drug use in most countries, and drug use is associated with increased risk of hepatitis B and hepatitis C, as well as HIV. We also criminalize sex work in many countries, and sex work has been associated with increased sexually transmitted infections, including HIV, but also the bacterial STIs. And we unfortunately over-incarcerate many racially minoritized groups who have been more prone to get involved with street work, sex work, drug use, and therefore the over-incarceration of these groups leads to the higher prevalence of bacterial and other STBBIs in prison. And you may also be asking yourself from the findings that I showed you, why is the prevalence higher among women compared to men in prison? The theory behind this is that women who are incarcerated have a higher prevalence of trauma secondary to childhood abuse and or gender-based violence. And an unfortunate consequences of this is that they tend to engage in compensatory drug use or compensatory sex work. And so as a result of that, have a higher prevalence of STBBIs. I did want to show you a table that I put together that looks at Canadian STBBI data, comparing the general population with federal and provincial prisons. Just to clarify, people in federal prisons have a sentence of greater than or equal to 2 years, whereas in provincial prisons, people have been sentenced for less than 2 years. The median sentence in provincial prison, the median duration of incarceration in provincial prisons is 30 days. So people there's a higher turnover in provincial prisons, whereas federal prisons, they're held for several years and therefore more likely to get into a bit of trouble with drug use. And so just to make the point that people in prison at a higher risk of STBBIs, I've put the latest data that I could find on the general population versus federal and provincial prisons. And a few just observations, just looking at this data, is that the HIV prevalence is 5 to 10 times higher in federal prison and provincial prison, respectively, compared to the general population. But saying that, it's still quite low. So typically what I quote is about 1% or just less than 1% in prison. Chronic hepatitis B appears to be lower in prison than the general population, but I will say overall it's completely understudied. So there's only one study out of Newfoundland in provincial prisons that has ever looked at this. The hepatitis C antibody, so an antibody to hepatitis C means someone has been exposed to hepatitis C. The most common form of transmission of hepatitis C is through injection drug use. And you can see here exposure is 15 to 20-fold higher in provincial and federal prisons versus the general population, respectively. So the most common STBBI in prisons worldwide is hepatitis C. Chronic hepatitis C, that's someone who tests antibody positive as well as RNA positive, i.e. they have current infection. Again, 6-fold higher in federal prison and 9-fold higher in provincial prison. So yes, if you want to go after people with hepatitis C to eliminate hepatitis C in Canada, prisons are a very high-risk setting. And despite the fact data that I showed initially, there's no general population prevalence data for syphilis, chlamydia, and gonorrhea in the general population. And so difficult to compare to, but suspicion is that having looked at other studies worldwide, again, higher in prison than general population. And you can see in provincial prisons, there's a huge range. So anywhere between 1% to 30%. And that again is highly dependent on the province that one is in. You can see Alberta, higher Indigenous populations who are incarcerated. Again, that racially minoritized group, their prevalence of bacterial STIs is, 1 in every 3 people. So again, depending on where you are in the country, prevalence of bacterial STIs in provincial prison is variable. Okay, so I'd like to introduce you to the PIC3 study. This is a study that I have led here in the province of Quebec for about 2 years now. Our primary objective is to determine the overall prevalence of sexually transmitted and bloodborne infections among people incarcerated in Quebec provincial prisons. So the STI bit is the chlam, gono, syphilis, and the bloodborne infections are the HIV, Hep B, and Hep C. And secondarily, to stratify the prevalence of STBBIs by sex among people incarcerated in Quebec provincial prisons. Just so you know, federal prisons incarcerate individuals by gender, whereas provincial prisons incarcerate people by sex. And so I'm conscious of the terms that I use when I am speaking of federal or provincial prisons. And again, this was the prior study in Quebec looked at HIV and Hep C prevalence in 7 provincial prisons back in 2013, 2014. And so when I was designing this study a decade later, and having been in this space for several years, it did not make sense to look at a couple of infections without looking at all of them, knowing that many of these infections co-occur in the same individual. And so we chose 7 provincial prisons in Quebec. We tried to replicate those prisons that were chosen a decade earlier. But since 2 of them had closed down, we had to replace them with something similar. There's 16 provincial prisons in Quebec, 2 of which are females. So we have in this group of 7 the 2 female prisons, and then the remaining prisons are men. Also, we chose prisons based on their location, thinking that urban settings like Montreal or Quebec City will have a higher prevalence than suburban like Saint-Jérôme or more rural settings like Baie-Comeau or Roberval. So it was to get a sense of whether also geography plays a role. And here you can see the population at each prison as well as the sample size that we went after. And the sample sizes were based on what I hypothesized to be the hepatitis C prevalence at each of these prisons based on prior work that I had done. And overall, we are looking to recruit almost 1,350 people across 7 prisons. You only see 6 pictures here because the Quebec prison is divided into a men's prison and a women's prison. So they're in the same building, they're in the same prison, but they are separate. And so for the purpose of this study, or sorry, purpose of this hour, I'm only going to take you through the results of the first 3 prisons that we recruited at. So in Montreal, Établissement de Détention de Montréal, located the largest provincial prison in Quebec, almost 1,400 people. That was our first prison. Then Saint-Jérôme, another men's prison, and smaller in a suburban area. And then Établissement de Détention de Laval, in Laval, our female prison, our largest female prison in the province. So I'm going to take you through our methodology in case this is of interest to anyone and there's a desire to replicate this work. And that was really why. So this is funded by the Public Health Agency of Canada. And they reached out to me to lead this work with the goal actually that other provinces would find our methodology interesting and potentially be able to replicate it. So we recruit individuals through convenience sampling. We have posters that we put up so people can sign up, and then we go systematically try to recruit areas in the prison that may have been underserved by our poster recruitment strategies. And individuals, once they are recruited, are brought into an office where they sign a consent form. And in the consent form, we ask for information detailing an emergency contact network. The reason why we do this is from a prior study that I led, which showed that when people are released from prison, oftentimes they lose their cell phone, they can't be reached, they don't know where they're going, and therefore providing an emergency contact network, be mom, dad, sibling, roommate, physician, social worker, if we're able to get that emergency contact network from someone, we are more likely, our last study showed that they are more likely to be reached following release from prison. So because these are high turnover settings, as I had alluded to, the thought process is that we are going to have people that are released from prison before they get their test results. And so we need a way of being able to contact them. So that was in the consent form. And then they hierarchically choose individuals like, I want you to call my mom before you call my dad. And we go in that order. And while we do not disclose the results to the emergency contact network, they help us locate the participant. At the time of consent as well, they complete a baseline questionnaire and receive $10 compensation, which is placed in their canteen accounts in prison. There's two sampling methods that we use: dried blood spot testing, which is basically you take your finger prick, it's a finger prick sampling, and we test for HIV, hepatitis B, hepatitis C, and syphilis through DBS sampling. DBS is not, unfortunately, a validated diagnostic test in Quebec, unlike in other provinces across the country. So confirmatory testing is required for any positive test, despite having very high specificities. The sensitivities are a little bit less. And so any positive test on DBS then undergoes confirmatory testing. I'll get through that. And then chlamydia and gonorrhea are tested through urine samples. We ship on a weekly basis the DBS test to NML, so the National Microbiology Lab in Winnipeg, and then the urine samples are shipped by car to OptiLab, which is our laboratory at the McGill University Health Centre. Once all the results are received, DBS has a longer turnaround time than the urine samples. We write individual memos where we write the positive or negative test result. These are anonymized, so there's no way, if someone loses their piece of paper in the prison, there's no way of tracking down the test results with the person. If all test results are negative, the individual receives a memo, says, all your test results are negative. There's nothing more to do for you. If any of the tests are positive, we attempt to link them to care with the nursing team in the prison. I will say that one of the big challenges of this study has been that one of the 7 prisons' nursing teams did not want to collaborate, not the nursing team themselves, but the higher level leadership, because they thought this was going to bring enormous work to their caseload. And so you'll see that where there was no collaboration, you'll see the impact of that on linkage to care. So anyone with a positive test, we informed the nursing team in prison. They did confirmatory testing on all positive DBS tests, but not on the urine samples. And then they were offered treatment in prison. If they were released, however, and they had a positive test result, our protocol states that we would contact them within 72 hours. Ideally, we contact them 3 times within 72 hours, so 24, 48, and 72. And again, we go through the emergency contact network in a hierarchical order, and we link them to care at a community health center that is closest to where they currently reside. And individuals have the opportunity to opt out of receiving their test results at the beginning of study participation and also being linked to care, which you'll see very few people opt out of either. And then here's the DBS card, which I think I'll show in a different slide, but the goal is to fill 5 circles with blood. And in discussions with the National Microbiology Lab, I was most interested in hepatitis C. And so if you're not able to fill the 5 circles, which we were not necessarily able to do at the very beginning, but now we have a 100% track record, this is the order of prioritization, as in we will first figure out, we will first do a test for HCV antibody, then HIV antibody, and then go down the list. And so syphilis is the last test that we are likely to get a result on. Actually, the HIV viral load is the last test we're likely to get a test on. But we'll talk about that shortly. So the results, as I mentioned, 3 prisons are finished. Actually, as we speak now, 5 prisons are finished, but I did not have the data to present. And we've recruited 60% of our sample after these 3 prisons. And believe it or not, we're at 85% now. So it's a tremendous success. So in the last year, from October 2024 to 2025, you can see here that the number of participants recruited is 2/3 male, 1/3 female. The median age across almost all prisons is 37 years. Interestingly enough, 1 in 5 people have reported, I have ever injected drugs in my life. But as I had mentioned previously, that prevalence is much higher in the female prisons, 27% versus much lower. You can see 17 and 13% flanking that 27% among the 2 male prisons. Recent injection drug use, defined as injection drug use within the last 6 months, is lower at 1 in 10 people, but again, higher among people, women in prison than men. What I've neglected to tell you guys is that when we collect DBS samples, my research team has been trained to offer individuals the ability to test themselves, i.e., I'm going to self-collect versus I am going to assist you in collecting. And I chose to do this. This is the first time I've done this in any of my studies because I always want to empower my participants, and especially people in prison who are often powerless in many situations in prison. And to my absolute surprise, I thought we were going to see an inverse. 90% of people would have wanted to collect their own samples, but in fact, very few have wanted to collect their own samples. And the majority feel as though that the trained research personnel, we have a qualitative study on the acceptability of DBS among people in prison, which I'm not presenting today, but many of the people chose not to self-collect because they felt as though the personnel, they really trusted the personnel and the team, and they felt as though it was a job best done for someone with training. And so that was a very interesting finding, and it has borne out in the 2 additional prisons that we've recruited. When you look at specimen turnaround time in days, when the specimen collected to when results were received, takes about over 2 weeks for us to get the results from NML, which is what they told us it would be. So to be fair, in line with what our expectations, and 11 days from OptiLab. But truly, we only ship once a week. So to be fair, the turnaround time should be measured from the date that they're shipped to the date the results are received. And you can see that does shave off several days. So now let's look at the prevalence of STBBIs among the 811 participants. So here you can see, just look at the overall prevalence. So you can see the overall prevalence, we do an antibody test, and then NML does a confirmatory total nucleic acid test. There's a high false positive with the antibody test. So really, in 811 samples, we only had 5 positive tests and not 13, for an overall prevalence of 0.6%. Remember, I told you the magic number is really under 1%, and that really has borne out to be the case in our study. Hep B, again, a low prevalence, 0.5%. Hep C, again, the most common STBBI at 7.4%, 60 of the 81, with 1 in 5 of those individuals still requiring treatment or retreatment had they been treated before. And then in terms of global trends, chlamydia being the most common, we're actually not seeing that. Syphilis is the most common, but again, just a reminder that on the DBS, it's an EIA sample, so it's an antibody detecting prior or current, so it is overestimated. So it may be actually that chlamydia is the most prevalent bacterial STI, given that syphilis is overestimated because clam and gono are current infections. Clam being more prevalent than gonorrhea. When you look at the numbers, men and women, you can see here that the prevalence of HIV is actually higher among women than men, just over 1% among women versus 0.4. The prevalence of exposure to Hep C is almost threefold higher in women than in men. The same proportion, so 1 in 5, had not been treated for hepatitis C. Syphilis, again, higher among women than men, as well as gonorrhea. So with the exception of Hep B, we're talking very low numbers here of Hep B. Chlamydia is really the only infection, surprisingly enough, that was not more prevalent among women compared to men. And again, though, you can see when you look at the total prevalence among women versus men, it's 2 versus 4, so a twofold higher prevalence of positive test results among women versus men. And then if we just look at location being key, so remember EDM is our Montreal prison, so we expect the prevalence to be higher than Saint-Jérôme, which is our rural male prison, and that has actually borne out to be true. And again, our female prison is higher than both of the 2 male prisons. Oh my goodness, we are getting to time. So I want to also just point out that about 20 to 25% of people in each of the prisons were released prior to our ability to disclose their test results. And despite our emergency contact network, we lost over 50% of those individuals. And then we just focus on those with a positive test result, again, there is still a high loss to follow-up rate. And even higher among the prison that did not collaborate with us. So individuals with a positive test result who then had to be linked, unfortunately, their linkage was terrible. I want to say that DBS test collection is something that is completely dependent on the collector and the patience of the collector with the participant. And so we started off doing, I would say, an adequate job. But over time and with experience, we now fill all 5 circles entirely and have not had to retest anyone. But such was not the case when we started off. And happy to walk people through, techniques that we use to try to get those samples filled. There's a lot of challenges of conducting research in prison. I won't go into this right now just for the sake of time. And some of the conclusions thus far from the PIC3 study is that the DBS turnaround time of almost 2 weeks is just simply too long, and 20 to 25% of people are released without their test results. And despite this emergency contact network, we're losing 50% of people post-release. And so this really argues for the importance of point-of-care testing, where the result is within minutes rather within days. Hep C is the most prevalent STBBI, and the prevalence of HIV, Hep C is several-fold higher than the general population, and prevalence of most STBBIs is actually several-fold higher among women versus men. So really interesting implications in terms of what we need to be doing in terms of systematic opt-out screening for all of these infections and thinking about gender-informed public health responses. And so there's so many people to thank with this work, as well as our funders. And that, I believe, I'll stop right there. So happy to take any questions at this point in time.